Hello, my name is Susan Littlepage, and I am a pharmacist on this cardiology unit. I'm going to speak on medications specifically for treatment following a heart attack, but many of these medications also benefit people who have had damage to their heart by other insults. The key is that there is evidence to show that each of these medications have proven mortality benefit and should help you live longer. First, medications that affect the blood vessels feeding the heart. This is a diagram demonstrating what happens to a diseased artery. The endothelium is the interior lining of the artery, and it is responsible for releasing chemicals to maintain the elasticity of the vessel. This lining becomes thick when the burden of plaque becomes too great. What is plaque? Generally, people respond with cholesterol, fat, but I assure you it is much more. It is a toxic dump of chemicals and cells intended to break down the cholesterol and ultimately get rid of this foreign substance. It is not a benign piece of butter, but rather an unstable cesspool of toxins, cells, and inflammatory agents. Your body not only tries to get rid of this toxic mess, but the endothelial lining will actually grow over top of it like a cap to seal it away from the rest of the artery. If or when the toxins become too corrosive, they can eat away at this cap and cause a lesion, sort of an inside-out wound. Blood passing by the lesion will leave platelets sticking to it, and that will start the clotting process. If the clot is big enough, it will block the artery, or the clot may break off and block the artery further downstream.
So what do? You come to our cath lab, and our interventionalist will determine where the lesion is and open the vessel with a balloon on the end of a catheter. Generally, the catheter has a stent compressed around the deflated balloon, and when the balloon is inflated, the stent is pressed against the walls of the artery. Once the balloon is deflated again and pulled out, the stent left behind. There is only one problem. The toxic dump is still there, just pushed to the side and probably outside its protective cap. Our bodies will react to these invaders, both the stent and the toxic mess, the same way. It will try to grow a cap over everything. I call this a callus, thick cells with no elasticity and blocking the artery's lumen. Stents have been designed with chemicals now that will limit cell growth. We want the stent to become encapsulated, but just with a thin wall. That is what these drug-eluting stents do. They allow growth, but only minimally, like plants trying to grow in poor soil. Before stents were dipped in chemicals, 40% of the people with bare metal stents had the same pain within a year. The stented artery filled up with a callus. Now, the drug-eluting stents, the rate has dropped to less than 3% within the first year. But everything comes with a cost. When our bodies cannot protect us by growing cells quickly, we will attach platelets to the stent and/or the toxic dump site, just like the lesion I described earlier, and start a clot or a scab over the entire stent. This happens quickly and can be life-threatening. That's why you are given a strong antiplatelet agent. In fact, you are generally given two antiplatelets, aspirin and a P2Y12 inhibitor, or superaspirin. Clopidogrel, or Plavix, Prasugrel, Effient, or ticagrelor, Brilinta. The P2Y12 inhibitors prevent the stimulation of platelets at the P2Y site, hence the name. See the tentacles on those white platelets catching the red blood cells? Platelets that are not stimulated don't have those appendages, and they're more spherical and smooth. These drugs help to prevent the platelets from becoming sticky and forming a clot. The superaspirins work differently from aspirin, so they can both contribute to preventing clot formation. The combination of aspirin with P2Y12 inhibitors is called DAPT, D-A-P-T, antiplatelet therapy. It is most effective when you receive a stent, although they can be of benefit without a stent after a heart attack. So what are the risks? Bleeding, of course. Clopidogrel, probably less than ticagrelor, and probably less than prasugrel, although that data is changing. Dyspnea, or difficult labored breathing, can happen with ticagrelor, as well as bradycardia, or a slowing of the heart rate, also with ticagrelor. Questions to ask your doctor or prescriber? Which antiplatelet agent is right for me, and why? Diabetes, risk of bleeding, cost, drug interaction, age, and weight all play a factor. Studies have shown that prasugrel is great for diabetics, but may cause bleeds in elderly people or people with low body weight. Also, prasugrel and clopidogrel are generic and then cheaper. Drug interactions can make some agents work too well and others less well. It gets complicated. How long do I need to take this antiplatelet agent combination? And what if I already take an anticoagulant for AFib? Do I still need aspirin? Now statins, otherwise known as HMG-CoA reductase inhibitors. I like them better. Most people think physicians prescribe statins after a heart attack to lower cholesterol, but that is only part of the story. What scientists have learned is that statins do a lot more. In one study, doctors found that in the first month after a heart attack, more patients lived who were treated with a high-potency, high-dose statin compared to the group of patients treated with a low-dose, low-potency statin. In 1 month. That was not due to lowering cholesterol. What they found is that these high-potency, high-dose patients had less inflammation in their arteries. Less inflammation means less instability of other plaque sites and less likelihood of another lesion and possibly another heart attack. Remember the unstable toxic dump? So yes, statins lower bad cholesterol and raise good cholesterol, and over time cholesterol deposits are resorbed. Plaque burden is lessened and the coronary linings can become more healthy. But acting as an anti-inflammatory to our arteries is a huge benefit in preventing further events. So what are the risks? If you were to Google statins, you would probably find liver damage listed. This is a concern from decades ago, but the FDA researched their databases and determined that there is no correlation to starting statins and causing liver damage. Muscle cramping can be either just a nuisance or life-threatening. Discuss muscle cramps or weakness with your doctor. Sometimes just changing statins or lowering the dose is enough to lessen the incidence of cramps. But severe muscle cramps that don't go away can cause severe muscle damage and a release of muscle into your bloodstream, which can overload your kidneys and cause kidney failure. If you are a borderline diabetic, statins may tip the scale. The FDA again looked at the data and determined that cardiovascular benefit is still there, even with the added risk of diabetes. Lastly, we cannot blame statins on memory loss. I think we're just getting older. PCSK9 inhibitors. Pro-protein convertase subtilisin kexin type 9 inhibitor. My last time I say that. Alirocumab, or Praluent, and evolocumab, Repatha, are both alternative agents in place of statins or in addition to. What they do and how they do it. PCSK inhibitors help lower low-density lipoprotein cholesterol, or LDL cholesterol, the bad cholesterol, by preventing the PCSK9 enzyme from binding to LDL receptors in the liver. These receptors are necessary for clear LDL from the blood. The LDL, or cholesterol, attaches to the receptor and then is brought into the liver to be broken down. PCSK9 triggers the action of these receptors, which is not a good thing. Risks are really minimal, except for the expense. Okay, so we have talked about the heart's blood vessels. Now let's talk about the heart muscle. After a myocardial infarct or heart attack, we looked at the damaged muscle over time. We would see that the muscle can become thin and the diameter of the dead tissue can expand. Think of a hamburger patty that you press into shape before cooking. This change causes surrounding healthy heart muscle to respond by elongating and becoming thicker. These stressed or stretched surrounding muscles send out signals in the form of chemicals, epinephrine and angiotensin II, out to the rest of the heart to bulk up. Bulking up to make up for damaged muscle wall sounds good, but this muscle adaptation to an injury is called remodeling. Becoming bigger and stronger to offset the injured site can actually make the heart misshapen and less efficient if gone unchecked. So, we have two types of medications that can hinder this remodeling with other great benefits for the heart. First, beta blockers. We love them all, but the dilated, bisoprolol, carvedilol, and metoprolol are our favorites, since they are of proven benefit if heart failure is present, which is one of the things we want to prevent. Beta-1 receptors are on the heart, and when epinephrine binds to the receptor, the heart is stimulated in many ways. Beta blockers stop that signaling, which is beneficial for the injured heart. Beta blockers block some of the effects of adrenaline on your heart, thereby decreasing the workload on your heart. It does this by slowing the heartbeat, lowering resting and exercise heart rates. It also decreases the force of heart muscle contraction, which in turn lowers blood pressure. It can help prevent irregular rhythms as well. And most importantly, it can help preserve the size, shape, and function of your heart. So no bulking up. Risks? Well, here they are. Fatigue, a slow heart rate, low blood pressure, and bronchospasm in asthmatics. Beta blockers have the exact opposite effect of rescue inhalers, and asthmatics may notice that. Questions to ask your doctor? First off, is more better? Do I have a gold dose due to muscle damage? If there's no muscle damage because you were treated early, then it should be just fine. More damage, higher doses are generally better. Also, how long will I need to take this medication? For life? Generally, yes. The other type of medicine that can protect the heart after ischemic damage addresses angiotensin II. Angiotensin II was the other signaling agent for the heart to pump. But angiotensin II is also a strong vasoconstrictor, squeezing blood vessels, thereby increasing blood pressure. It is made from angiotensin I, which floats around in your bloodstream doing pretty much nothing at all, or at least that we know of. The first column on this screen lists our ACE inhibitors, or prils, lisinopril, ramipril, clinoprilol. These agents block angiotensin I from being converted to angiotensin II. The other list is a list of angiotensin II blockers, otherwise known as sartans in my book, which block the angiotensin II receptor. So angiotensin II has nowhere to work. What they do and how they do it. By blocking angiotensin II, this leads to a decrease in blood pressure and sodium retention. It also reduces the workload on the heart. It can help preserve normal heart shape, size, and function. No more signaling from damaged muscle. With the added benefit of protecting the kidneys, delaying the onset of kidney failure in people with high blood pressure and diabetes. Win-win. What are the risks? Kidney dysfunction. I just thought it was better. Well, it can also lower pressure in the kidneys, which is the kidney's ability to filter. You need pressure to filter. This is most often seen in elderly kidneys. High potassium, we'll need to monitor for that. Angioedema, which is swelling, especially around the face and throat, mostly with ACE inhibitors. And also cough, again with ACE inhibitors. Remember angiotensin I? If angiotensin I cannot be converted to angiotensin II, it then congregates in the lungs and causes you to cough. No harm, but it can be a nuisance for some people. Questions to ask? Well, is more better? Do I have a gold dose due to muscle damage? Or do I need it at all? How long will I need to take medication? For life? If no heart damage and no hypertension, it may be an optional drug. This is my new category, since these medications have just recently been approved for cardiac indication. GLP-1 receptor agonists. otherwise known as glucagon-like peptide 1 receptor agonists. A mouthful. Names don't get easier. There are only 3 of these agents that have FDA approval for cardiovascular disease to date. They are the ones in the circle: dulaglutide, or Trulicity, liraglutide, Victoza, and semaglutide, or Ozempic. You may have seen commercials for these agents. GLP-1 agonists mimic GLP-1 hormone. GLP-1 is a gut-derived glucose regulator that is released after the oral ingestion of carbohydrates or fat. In patients with type 2 diabetes, unfortunately, GLP-1 concentrations are blunted. But this hormone does so many important things. It increases insulin secretion, but only when glucose levels are elevated, like after eating carbohydrates. It also inhibits glucagon release, thereby lowering glucose production. GLP-1 promotes beta cell proliferation, which means cells that make insulin. And then it also slows gastric emptying, which makes one feel full and reduces food intake. GLP-1 does not increase insulin secretion or suppress glucagon secretion at normal or low glucose concentrations, so the risk of hypoglycemia is very low. That's what it does for diabetes. But now there are also effects that are good for the cardiovascular patient, but we don't have good medications for them yet. GLP-1 agonists lower the risk of cardiovascular death, non-fatal MIs, and strokes by 12 to 26%. It can improve endothelial function, that lining within the arteries, and improve vasodilation. It also increases sodium excretion, thereby decreasing blood pressure, and it can decrease inflammation in cardiac arteries that may cause unstable plaque. What are the risks? Nausea and vomiting are most common. The recommendation is to eat smaller meals and titrate the dose up more slowly. Questions to ask your prescriber: which agent is right for me? Injectable versus oral? There's more data on injectable. Also, am I at the best dose for me? More is generally better if you can tolerate it. And do I have a higher risk of adverse reactions? Each product has a subset of patients that may be more at risk. It is worth talking to your doctor. The other group is SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitors. These are the flozins: canagliflozin, dapagliflozin, and empagliflozin. What do they do and how do they do it? SGLT2 inhibitors block resorption of glucose and sodium by the kidney. The sodium glucose transporters in the kidney account for 90% of glucose resorption. Blocking these transporters results in glucose being excreted in the kidneys, usually a sign of diabetes. sugar in the urine. Also, the excess sodium excreted is like taking a diuretic. Salt and water are excreted. Ultimately, this causes a lowering of blood sugar levels, diuresis, and lowering of blood pressure. The lowering of blood pressure and blood sugars reduces workload and congestion on the heart and slows the progression of diabetic kidney disease. The cardiovascular benefit is significant. Reduction in cardiovascular death is approximately 38%, and lowering the risk of heart failure hospitalizations is anywhere between 26 and 39% reduction, depending on the study. How do we do it? Well, there are proposed mechanisms, including dilating arteries to improve blood flow, preventing heart muscle fibrosis, the heart becoming stiff, and increasing red blood cell production and improving oxygen supply to the heart. But it could just be workload reduction by lowering blood pressure and fluid retention. We just don't know. What are the risks? Infection is a significant risk. Genital fungal infections are 3 to 4 times greater risk than people not taking this medication. Urinary tract infections, 2 times greater. Diabetic ketoacidosis with normal blood sugar levels, which is a little complex for physicians to diagnose, and that increases. Lower limb infections, 2 times greater risk, and a possible increase in bone fracture with one of them, canagliflozin. So it is a benefit-risk decision. Questions to ask your doctor: which is right for me? And do I have a higher risk of adverse reactions? And if so, which would be the best agent to choose? That's it. This is where I say thank you. It's a lot of information, and I hope a few pieces of information might apply to you. It's becoming more so. But there are many ways that we can help you live longer with cardiovascular disease. Thank you for your time.